All right. Good afternoon, everyone. Thank you for joining us for the Missing Link, Improving Transitions of Care for Patients with Bleeding Disorders. My name is Gabrielle Gassaway. I am the Community Health Program Manager at Accessia Health, and we are excited that all of you could join us for what I am sure will be a very enlightening session today. Before we get started, I just want to cover a few housekeeping items. First, all lines are muted throughout the duration of the webinar. However, we welcome you to submit your questions through the Q&A throughout the event using the Q&A function at the bottom of your screen. There will be time at the end of the presentations to answer any of your questions. For the convenience of some viewers and those who might be hearing impaired, closed captioning has been turned on. Also, this webinar is being recorded and will be available at accessiahealth.org. Really quickly, just want to give a small bit of information about our organization for anyone who may not be familiar. Accessia Health is a national nonprofit dedicated to addressing the needs of people with rare diseases and chronic conditions. We have a unique approach to traditional patient assistance that is holistic, inclusive, and outcomes focused. Our disease-based programs cover a variety of healthcare expenses, including copays, premiums, and travel expenses. To learn more about our organization, please visit our website at accessiahealth.org. Accessia Health webinars, events, and conferences are intended to provide information to the public. Please note that the views and opinions expressed by any of our speakers today or other third parties are not necessarily those of Accessia Health. Without further ado, I would like to introduce you all to our moderator for the afternoon, Ms. Karina Lopez, who is a Health Access and Strategic Innovation Project Specialist at the National Bleeding Disorders Foundation, where she's been since 2015. Her work focuses on health equity, with a particular interest in real-world data to address and understand barriers for marginalized communities. I'm going to hand it over to her, and she'll be introducing you all to our speakers for their presentations. So, Karina.
Thank you so much, Gabrielle, for that warm welcome. My name is Karina Lopez, and I am the program specialist at the National Bleeding Disorders Foundation, which was formerly known as the National Hemophilia Foundation. In 2023, we rebranded to be more inclusive of all bleeding disorders. So now we are the National Bleeding Disorders Foundation, or NBDF. I wanted, similar to what Gabrielle did, I also wanted to provide a brief summary or our mission statement at NBDF. We are dedicated to finding cures for inheritable blood and bleeding disorders and to addressing and preventing the complications of these disorders through research that has a measurable impact on people's lives and always including our lived experience experts or leads at the center of what we do from the very beginning to the end. We deliver education that is culturally and linguistically appropriate for people with bleeding disorders, and we advocate for policies at the state and local level that protects access to healthcare to enable people and families to thrive. That last sentence, that last section is really our goal as a patient advocacy organization. We always like to include our mission statement in Spanish as well for our Spanish-speaking stakeholders. And the visual that you see on the right are the principles that guide our policies, programs, decisions, and actions. And if you want to learn more about NBDF, please visit www.bleeding.org. And now, without further ado, I will welcome our first speaker of this webinar, Maria Tovar Herrera, who is a registered nurse who has worked in the bleeding disorders community for many years. She worked as a nurse coordinator at the Hemophilia Treatment Center at Rush University Medical Center for 8 years before retiring to care for her first grandchild. I love this. She is still involved in the bleeding disorders community as a speaker for education for empowerment through the National Bleeding Disorders Foundation and as a consultant for the Hispanic Bleeding Disorders Alliance through her local chapter, the Bleeding Disorders Alliance of Illinois. With both groups, she continues to educate and advocate for patients with bleeding disorders. She is bilingual, speaks English and Spanish. Welcome, Maria.
Thank you. Thank you so much. It's a pleasure to be here. And I hope that you get some good information out of this presentation. So the title of our presentation is The Missing Link, Improving Transitions of Care for Patients with Bleeding Disorders. Next screen, please. Our objectives are, I will describe current diagnostic approaches and clinical treatment protocols for managing hemophilia and other bleeding disorders, and recognize common gaps and barriers in the transition of care between hospital, outpatient, and community settings. So, diagnosing a bleeding disorder. I think the most important part of diagnosing a bleeding disorder is a good family history. I worked with a physician that really focused in on this because you need to get a good family history. Lots of times, the little things that you pick up during that family history will help you in the diagnosis. It's not just one possible diagnosis that there can be. There are different types of bleeding disorders, and some patients can have more than one bleeding disorder. So you need to ask, first of all, if anyone in the family is known to have a bleeding disorder. And if the answer is yes, then that's going to make the journey a little bit easier, because then you know that you kind of know what you're working with and you can take it from there. And if there's any family history of bleeding episodes. For many of us, I know that it's in the past, for different medical diagnosis, our families didn't talk about many things. It was like we just didn't talk about different issues. And one of the ones that we focus on too is in women. In the past, women did not talk about their menstrual history or what they were feeling or what was going on. And many times when women brought that to their family's attention, that they were having heavy bleeding, they were told that that was normal. So you need to ask about bleeding episodes. We had a family in the HTC that immigrated from Mexico, and the woman's son was 7 at the time and was diagnosed with mild hemophilia A. As we started talking more with her, she talked about losing a sister to a postpartum hemorrhage. She had a sister that delivered a baby, and she passed away during the delivery because of the hemorrhage. She also mentioned that her father, the child's grandfather, maternal grandfather, they lived on a farm. And because it was a labor-intensive job for him, lots of times he had swelling at his ankles, at his knees, and his elbows. And those were all taken care of as if he had maybe strained or sprained that joint, when in reality, it could have been that he was having a bleed at the joint. She also mentioned that he was riding his horse. He fell, and when he fell, he did hit his head, and that they said that he died of a head bleed. So it is possible. Of course, it was there was no diagnosis at the time, and in reality, they didn't know much about the bleeding disorder until the 7-year-old was diagnosed to have mild hemophilia, and now she has also had testing, and she also has mild hemophilia. So a family history is very important to ask all the questions, because you could pinpoint and get good pointers from there to lead you in a positive direction. Next screen, please. So diagnosing a bleeding disorder. We talked a little bit about the family history and symptoms in the family history or episodes in the family history, but then we also had to ask about patient symptoms. So what are the symptoms the patient is experiencing? So the bleeding history, are they having nosebleeds? Is there prolonged bleeding after a laceration? What if they're female, menstrual bleeding? What is the history with the menstrual bleeding? If they have delivered a child, Was there a hemorrhage or heavy bleeding after the delivery? Gum bleeding. Brushing your teeth. If you're brushing your teeth, do you have gum bleeding after that? Or have you had a dental procedure where you have had prolonged bleeding after the procedure? Did you have to go back to the dentist? Or did you have to visit an emergency room perhaps for the bleeding that was just prolonged after that procedure? These are also very important questions and that need to be asked during that diagnosing phase. Bruising history. Are you an easy bruiser? Do bruises that you have take longer to heal? How often do you get those bruises? I know that we've also had families in the past that were reported to the Department of Children and Family Services by a school teacher or by the school or by a daycare center because the child had bruises. And some of the bruises were perhaps where you would take the baby to hold him up by his arms to carry him, or to hold him by his legs. And the daycare centers then were questioning parents about the bruising. So asking a good history for bruising is also essential. And then swelling at the joints. Are you having swelling at the joints that's painful, that's warm to touch? Is it something that's recurring, that you continue to have perhaps the swelling at the joints at a certain joint that keeps swelling, an ankle, an elbow, a hip, a knee? These are all very important questions that are needed to be asked during the bleeding history, because again, these can provide us with some clues as to the diagnosis. Next screen, please. So in diagnosing the bleeding disorder, it involves doing screening tests. Some of the initial screening tests are a complete blood count, prothrombin time, activated partial thromboblast time, followed by more specific coagulation factor tests to measure the levels of activity of specific clotting factors if the initial screening is abnormal. These specialized tests can help identify specific conditions like von Willebrand disease or hemophilia or other bleeding disorders. And it's also essential that these are done hopefully at an institution that provides or has this testing on site. If it does not, and they have to be sent out, obviously that's okay. I know that there's different medical centers and not everybody has laboratories on site that can do these on site. But these are some of the tests that are done initially. Next screen, please. So a complete blood count, or what we call a CBC for short, it checks the number of platelets and other blood cells. It's important to check the platelets because there's also bleeding disorder that affects platelets. So we need to see what the platelets are. Prothrombin time, the PT test, measures how long it takes for the blood to clot. It is often reported in International Normalized Ratio, INR. Activated partial thromboblastin time, an APTT test. This is another test to measure the time it takes for blood to clot. And fibrinogen and thrombin time, TT. These are often included in initial screening panels to help evaluate clotting factors. So these are all parts of the puzzle that we're putting together. Next screen, please. Additional testing that may be done based on the results of the initial screening are a platelet aggregation. A platelet aggregation test measures the ability of the platelets to clump together, aggregate, and form clots, which is essential for hemostasis or stopping the bleeding, because usually the platelets are first on the scene to start that clotting process. Von Willebrand testing. Von Willebrand factor antigen and von Willebrand activity and ristocetin cofactor are levels that are checked for this test. Factor assays. Factor testing for bleeding disorders involves a blood test to measure the activity of specific clotting factors, which helps diagnose and the type and severity of the disorder, like hemophilia. But there are other factor disorders that are a little more specific or different. So for more specific factor assays, like factor 8 and factor 9 tests, those are done so that you can pinpoint the exact deficiency. In some cases, genetic testing and inhibitor testing, Bethesda tests, may also be performed. Now, with factor, we're all familiar, or many are familiar with, that are familiar with hemophilia know that there's hemophilia A and B, so it's a factor 8 deficiency or a factor 9 deficiency, but there are other factor deficiencies. There's factor 5, factor 7, factor 13, factor 12, factor 10, to name a few. So it's very important to get these tests done. The other thing is we need to be a little patient, because sometimes we do these tests and they come back normal, and you're still trying to figure out what exactly is going on. So sometimes the initial tests are done, then you move on to do more specific tests. And then if those are normal and there's still bleeding episodes going on, then you move on to do even more specific tests. Next screen, please. Genetic testing is one of those tests that's done for bleeding disorders, and it's indicated after conventional coagulation testing has identified a deficiency or an abnormality, and acquired causes have been ruled out. So sometimes this is done when a patient has a diagnosis of hemophilia, perhaps, and no one else in the family has it. So it's an acquired case that they may have. And so genetic testing is done so that they can see exactly and pinpoint where it came from or how this person got it genetically. It is also recommended when there is a clinical suspicion of a hereditary disorder due to family history of bleeding or an unusual bleeding pattern. So for example, the case that I gave with the family that immigrated from Mexico, where the little boy was diagnosed at 7, there was no family history that they knew of that anyone had a bleeding disorder. And some of the bleeding episodes that were discussed during the initial screening were not taken as anything serious or anything that may have been a bleeding disorder. And in reality, this particular family had not even heard of hemophilia before. So this was all new to them. Next screen, please. These are some treatments. Once you have your diagnosis for your bleeding disorder, there are different treatments that can be done. So there is factor replacement, which is the what is usually the treatment that is done. And it's therapeutic because you are replacing what is deficient in the patient. So there's standard products, and then there's extended life products. So those products that last a little bit longer so that patients don't have to infuse as much. But these are all given intravenously. So they have to be given in a vein. And I know Dr. Soto is going to talk a little bit more about transition, but when you are in an HTC, transition starts the minute of diagnosis. So once there is a diagnosis and we discuss with the patient or the family, if it's the parents of a child, we discuss what treatment options are, and then we start the transition process where we are transitioning this care from helping to transition this care, I should say, from the providers to the family members of the child, or if it's someone that's going to have assistance from a caregiver or the actual patient. You know, we need to transition this so that they can then start to do their own treatments. And we always ask for participation in their treatment. And for the children, we used to start as young as 4 years of age, not teaching them to infuse at 4, but we wanted them to get involved in their treatment. So maybe getting the Band-Aid, opening the Band-Aid, getting the alcohol pad, getting the box of factor, just whatever they are comfortable with. And then from there, we would proceed to the transition where they would then take over their treatment, obviously as they get older if it's a child. Other types of treatment are non-factor related, and that's like your Hemlibra and your other products that are out. Oh, I'm sorry, my screen moved. Himpavzi, Elhemo, Qfitlia. And then there's also DDAVP and anti-fibrinolytics. So these all promote clotting without replacing the missing clotting factor. So the Hemlibra, Himpavzi, Elhemo, Qfitlia, those are all given subcutaneously. And those are new products that are out on the market now for treatment of hemophilia. And so those are all great because they're given subcutaneous. And that is a big, in my eyes, after being in the care of patients with bleeding disorders for so many years, this is great because it can be a challenge to providers and to family members to get that infusion in peripherally. So doing subcutaneous, there still may be a fear of needles, but at least it does not entail having to find a vein for the treatment. Some of these are still intravenous. DDAVP is still intravenous. DDAVP can be given to patients with platelet disorders, or it can also be given to patients that are, I'm sorry, I lost my train of thought. It can also be given to patients, DDAVP, that have other bleeding disorders, von Willebrand disease in particular. Antifibrinolytics, those are oral, and those are usually tablets or a solution. That's your Amicar and Lystata. Many of those are used after dental procedures. I know that some people use the solution of Amicar to help to form the clot formation if there is an extraction done. And also the Lystata is used for women during their menstrual cycle. There are some women that have mild hemophilia that during their menstrual cycle may require an infusion of factor. So if the antifibrinolytic is not working, then it is essential that you discuss that with your provider because women shouldn't have to suffer through their menstrual cycle with the heavy bleeding. The bypassing agents for those patients that have inhibitors. So there are bypassing agents that are used to treat patients that have inhibitors. And then the bottom of that screen is then genetic therapy. I did take this screen from our talk from last week. This was the different types of FDA-approved therapeutic treatments for bleeding disorders. So I just wanted to bring it up again because I wanted to share that this is a lot. When I first started as a nurse and started working with patients with bleeding disorders, we did not have this many products. And it's great that we now have all these FDA-approved treatments for patients so that patients have a choice on what their treatment is. And also, it's important that patients have a choice or that they choose what works for them as far as treatment, because what works for one patient doesn't always necessarily work for another patient. So that is just, it's great that there's this many treatments out there. So I just brought this up because I wanted to share that again with everyone. Okay, next screen, please. So treatment for a joint bleed. I thought it was important to mention this because along with the treatments for bleeding episodes, there also has to be more than just the factor replacement or other treatment replacement that's being done. It's very important because we try to protect our patients' joints as much as possible. So if there are joint bleeds, we typically do the RICE method, RICE method. And RICE stands for rest, where you would limit the use of the affected area to allow the bleeding to stop. You would apply ice packs for 10 to 20 minutes every 1 to 2 hours to reduce the swelling and pain. And then compression. You might want to wrap it so that it helps to help limit bleeding. And then elevation. Raise the injured area to reduce the swelling. And these are very, very important. And follow your treatment protocol. I recall from last week's session that we had that Dr. Escobar mentioned treatment protocols, and that when their patients were in their came to the HTC for their appointments, they all had copies of their treatment protocols. And that is very important. I used to tell my patients to carry a copy of their treatment protocol. If mom and dad, if it was a child, if mom and dad both had a car, put one in mom's car, put one in dad's car, put it in the glove compartment so you have it with. Carry a copy when you travel. If the babysitter, the daycare center, make sure they have a copy. And also grandparents or other caregivers, family members, just so that you have that treatment copy with you, so that if there is an episode and you go to a location, even if it's the same emergency room or urgent care where your HTC is, it's important to carry that treatment copy with you. Also, used to tell my patients, if you are traveling more than an hour and a half, 2 hours from your house, from your home, take your treatment with you, take your factor with you, take the treatment protocol with you so that you have that. Now, after each visit for your comprehensive clinic, which is where we used to go over the treatment plans in more detail and change whatever needed to be changed, it's also important that you get a copy after that visit and keep updated copies with you and share with your family. And it's important. And I think that this is why I know that HTCs is sometimes it's hard depending where you live. They may not be close, but I think it's important that if you have the opportunity, you should be part of an HTC so that they can really help you get all these things in order. And as I mentioned, also help you with the transition, your transition period. Okay, next screen, please. So in summary, in order to diagnose a bleeding diagnose a bleeding disorder, it's very important to get a good family history and a symptom history. As I mentioned, you need to ask the appropriate questions. You may also at this time want to give them, NBDF has this great menstrual chart that you could give women. That would be great to give out so that women could start keeping track of their menstrual bleeding. If there's nosebleeds involved, make sure that they keep track of the nosebleed, how long it lasted, so that all these pieces can fall into place. As I mentioned, they were all pieces of a puzzle that we're kind of doing to get together and get a diagnosis. Labs need to be done that are necessary to diagnose a bleeding disorder. Again, I know that this can be an issue depending on insurance. I always say insurance, we can't live with it, but we can't live without it. So it's very important to make sure that tests are done. If you are being seen and you feel that you are not getting the answers, you could always get a second opinion also. It's very important. If you can't get the answers from the first physician, then you may need to see another physician to keep working on what your diagnosis is. And work with the patient and the family on the treatments that they would like to use. I think this is very important. I think patients and families, they need to be involved in the treatment, in their treatment, so that they can be part of it and know. And as I said, what works for one person may not work for the other. So it's important to also listen to what the patient is saying, because they may need to try a different treatment protocol. And again, I'm going to encourage patients to carry a copy of their treatment protocol with them at all times. That is very important because if there's ever a need or an urgency, you need to keep that with. I know that now there's what we call here, I'm in Chicago, so there's what we call Care Everywhere, and I believe it's in other states now too. So if you're part of a HTC where Care Everywhere is used, then that's great, because then those can be shared with other providers. Your records can be shared with other providers where you go. Oh, and carry your factor with you also. This is another important thing that I meant to mention, because not all hospitals carry factor, and those that do may not have the product you use. So make sure you carry that with you. Next screen, please. Oh, that's all for me. So thank you so much for your time and attention. If you have any questions, I'll be happy to answer those after our presentation at the question session.
Thank you so much, Maria, for a perfect and excellent presentation on diagnosis and treatment of people with bleeding disorders. I will now like to introduce our next speaker. Dr. Leslie Soto Velez is currently an associate professor at the University of Puerto Rico School of Medicine, Department of Pediatrics, Hematology Oncology section. She is the director at the Comprehensive Hemophilia Treatment Center of Puerto Rico. She is also the director of Puerto Rico Newborn Screening and Inherited Diseases. Welcome, Dr. Soto.
Hello, good afternoon to everyone. I will be talking a little more about transition, and especially transition here in Puerto Rico, which is our experience with the limitations we have. Next slide, please. Okay. What is transition? Well, transition is a process or a period of change. So everybody of us, even if we do not have any bleeding disorder, we will have transitions through our lives. When we transition from high school to college, that's a transition because we are going to a different kind of school and education. Sometimes we also had to move from our home with our parents to live alone during that period. So that is a transition in our life. Also, when we transition from one work to another, so transitions are periods of change. In hemophilia, there is no exception. We will have different periods of change in transition. Like Maria said, transition in hemophilia and in bleeding disorders in general is a process that begins since the moment the person is diagnosed and lasts throughout the lifetime. In our hemophilia world, they will pass through many transitions during their life, like transitioning from the pediatric care to the adult center, or when they are moving to college and they have to leave their parents' house, so they have to start being independent and take care of themselves and be on board of everything that usually maybe the parents were on board of. Also, the transitions when they are changing medical insurances because of work or any kind of changes. And so transition is new stages. And for everybody, any kind of transition can get us a lot of anxiety. So it's very important for us at the Hemophilia Treatment Center to help them and to educate the families and the patients so this process is smoother and easier than it can be if they don't have that kind of help. Next slide, please. Okay, now because we are talking about the Puerto Rico experience, I'm going to introduce you to my team here in Puerto Rico. I'm pretty happy because until like 2023, I was only me and my nurse, Michelle, that is the one in the center. But like for almost 2 years from now, I have more help and more hands here at the center. So we have Dr. Samuel Pavon, that is on the left. We have Ana Quiñones, that is our social worker. Michelle Guzman, that is our nurse. That's me. And Dr. Moises Garcia, that is one of our pediatric hematologist oncologists too. Also, we have Dr. Rosa Diaz that helped us during the Hermansky Putla clinic too. So our center in Puerto Rico is a pediatric center. So we have patients from birth to 21 years old. About 85 to 90% of our patients are covered by Medicaid, that in Puerto Rico is called Vital. We do not have a 340B program, so we are very limited in resources. Our funding goes through the 2 grants from the hemophilia regional centers. We are from the New England Region 2, and we have 1 grant from the CDC and 1 from HERSA. Those are our only funds. And our coagulation laboratory closed in 2018. So we need to use reference labs for our laboratories. That's our center information. Next slide, please. For the adult population with bleeding disorder in Puerto Rico, they don't have a formal adult hemophilia treatment center. Also, they do not have coagulation laboratories at the University Hospital for Adults. Puerto Rico is a small island, but sometimes because of the geography, it's kind of a little difficult with the difficulties of the family of getting to San Juan, that is where we are located, and where the adult center is located, that even though it's not like a formal HTC, their program see most of the patients with bleeding disorders, especially hemophilia, because the only centers for adults that have factory in Puerto Rico is at the University of Puerto Rico and the ASEM system, that is our only Puerto Rico tertiary hospital, and a hospital called Menonita Hospital in Ay Bonito that is in the center of the island, because most of the hemophilia population in Puerto Rico is from the center of the island, like Ay Bonito, Barranquita. Next slide, please. Okay, why it is so important, this transition? Because throughout the life, we will have different needs. The needs of a person with a bleeding disorder at birth or during infancy is very different from the ones of an adult, especially because during that time, most of the needs are more from the parents, like getting introduced to the condition, how to work with the patient, how to treat the patient, coping with the condition, and teaching the kids how to cope with the diagnosis and how to balance their life. Then when they are older, they have different struggles, like getting to school, getting used to maybe get into the treatment that my classmate doesn't have that treatment, social problems, etc. Then during the pre-adolescence and adolescence, we have different also impacts, especially in the psychosocial area. And then when we get to adults, we have different responsibilities. So we will have different needs, and this can impact also our life, and this can impact also our treatment. It is really good that now, like Maria presented, we have a lot more of alternatives for the treatments of hemophilia compared like to 10 years ago when I started in the hemophilia world, that we only have factor, standard half-life factor, that needed to, especially for prophylaxis, needed to be infused like very often. And now we have several more different kind of treatments that we can choose, and they make our life easier, and they can adapt. It's like an independent and individual treatment, so they can adapt to our lifestyle and our goals and what we want to do differently from like 20, 30 years ago. Next slide, please. Okay, how is transition in Puerto Rico? We don't have a formal transition clinics for bleeding disorders. It was way before that I started in the center 10 years ago. They had an adult practitioner at the clinics, but with the cuts in funding, they didn't like follow also the adults. They had like the adult treater for the transition of the adolescents, so they can get used to a new doctor. But then when they got 21, they had to be transferred to the adult center, so to the adult hospital or the adult treater. So we don't have a formal transition clinics. And as I said before, we don't have a formal HTC for adult patients, although most of our patients are followed at dermatology clinics at the university hospital. So when I started the center 10 years ago, I started like touching the door. So see if I can start doing some transition clinics, start like interesting the adult treaters to get into the center so we can share clinics and we start this process. At this time, this haven't been possible, but I still struggling with that. And I will not get defeated. So next slide, please. So what we did, when I started the center, after that time, Hurricane Maria arrived to Puerto Rico. And with Hurricane Maria, even though it was a really difficult thing for Puerto Rico and for the island, for the bleeding disorders community, it put us on a spotlight. And then like the different national associations came to Puerto Rico and helped us to reconstruct our local chapter. So with having a stronger local chapter, we had more voice and we had more help in educating the community. So with the Puerto Rico Asociación Puertorriqueña de Hemofilia, that is our local chapter, we did some focal groups in 2018 for the adult community. So we can address the needs of the community. So we can start doing advocacy and we can start doing some changes for the adult populations. The bad thing was that only 2 adults attended that focal group. So we didn't get defeated. We didn't said we're not gonna do anything more else. So we started touching doors and we started talking with the adult practitioners to see their feedback on what they needed, what they found, because it was difficult like to get one of them interested like in only focusing on bleeding disorders. So what they said that was that patients arrived to the adult clinics without completing the venipuncture training, that parents still wanted to enter to the rooms with them. So they didn't speak, it was the parents. So I took all that feedback and we all united and we started doing some changes. Next slide, please. So if we were touching doors and we didn't have any answer and we have all those struggles and all those problems, well, with those lemons, let's going to do some lemonade. So let's make sure that if our patients are going to a chaotic world, that even though we are trying to make that for them easier, but it's not that easy for us, let's give them all the tools they need. Let's make them be as educated and as prepared as they need to be so they can be prepared adults. That's the important thing of transition. And even though it was Michelle and I alone, we started doing all this together, and now we are doing more with our team. Next slide, please. Okay. Also, as part of our HTC grant initiatives, we are working with them in quality improvement programs. And through our quality improvement research and programs, we started developing several quality improvement to make adolescents more aware of what is transition, to see which were the needs more important for them. And with the help of the NHCCP and the QI developing program, we developed last year our transition policy and plan, a formal policy and plan. So now that we are a little bigger center that we were, we all follow a uniform plan and an uniform structure for the transition of our patients. We are starting the formal transition to adulthood program at 14-year-old, although since the beginning of the diagnosis, we are doing different transitions, but more accordingly to that part. We are doing the annual screening of readiness for transition, and we started doing some focal groups with the patients, as I mentioned before. So we educated one-on-one them, and especially when they are together as adolescents, they felt a little more comfortable, like sharing and asking. And also we did some presentations. We also handed in some written information. We found out that one of our biggest difficulties was the venipuncture training. Sometimes patients were not interested, parents were taking all the time control, they didn't have time because of school. So last year, we had our first intensive venipuncture boot camp for patients. So we were very happy because we were trying to make that dream come true for a long time. So last year, finally, we had our first. So we are planning this year to have 2 or 3 sessions from the boot camp, and the patients were really happy and they really enjoy it, and they're starting practicing and being more independent. Also, we start, even though that the formal transition program we started at 14, we start like familiarizing them with the transition process, talking to them about it since 12 years old. Next slide, please. Okay. And we have an individual transition plan for our patients that, according to their specific needs, an individual plan is determined with short-term and long-term goals. And that plan is discussed with both the patient and with the parents. We start at 14-year-old, they start entering alone to the office. So they have to talk by themselves. We start evaluating their knowledge, and we start answering questions and discussing some areas of gap of knowledge that we notice. Then in each visit, we assess if they are following their transition plan, which goals are accomplished, and which goals are in process, and which goals we need to do a little more awareness on the need of completing those goals. Next. Okay. Which are the important goals to achieve for a successful transition from pediatric to adulthood? It's very important to know the condition and the complications of the condition, the treatment and how that treatment is administered, and how and why is that treatment administered like that, especially the mechanism of action of the product they're using, and what to do when they are having breakthrough bleeds. Also, they have to be aware of which is their medical insurance and what kind of different things they have to do, especially in Puerto Rico for the Medicare. They have a special coverage that we have to request, and where they have to call if they have any problem with insurance. Also, we teach them how to get the medications, which is their specialty pharmacy, how to ask for the refills of the prescriptions, everything of that. And it's very important that they know their medical team and how to contact us, especially in emergencies. Next slide, please. These are a photo from our first patient venipuncture boot camp. Next. So something really important and that had helped us a lot, especially when we are very limited in resources, is education. And partnering with the Hemophilia Association has been very important because they have helped us a lot in that, and has helped us also like getting us getting to more people that maybe are not visiting at the clinics, but through their activities, we can get to those persons that are already adults and help them to get educated and help them sometimes like even where to get the treatment. So it's very important. In Puerto Rico, we started 2 years ago to do a family symposium for patients and family members. It's called MOIN. MOIN is the Taino, that is our um, in our indigenous culture in Puerto Rico is blood, is the word for blood. Also, we do every year the summer camp, and the advocacy days is a day that community members go to the Senate to advocate for the bleeding disorders. And on April 17, we do the Rojo por la Hemofilia, is on red for hemophilia, so everybody dressing red in awareness for hemophilia and bleeding disorders. Next slide, please. Those are some of the photos of our our chapter advocacy activities. So we still have a lot of path to go through, but the important thing is to continue. What else can we do? We need to work together with adult treaters. We are going to continue like touching on the doors, like ringing the bells, to the fellowship training of the adult hematologists, oncologists, so they can be more exposed to the hemophilia community and the bleeding disorder communities and get them trained. Also, we are having some meetings for a possible liaison with the MedPits program, so we can start formally a transition clinic where we are going to train them in transition, and hopefully from transition we can go to an adult HTC, or maybe if we have the resources or the manpower, we can do a lifespan HTC. So hopefully in the next couple of years, that would be a dream come true. And doing a lot of educational conference for both patients, health professionals, and doctors, because there's still a lot of lack of education in the community today. I was talking to one of the patients, and she told me like she was talking to a nurse, and when she told him that she had von Willebrand, he looked like her like, what is that? So we still need to educate everyone about and make them aware of the bleeding disorders. Next slide, please. So thank you for everything. Let's now get some time for the questions.
Thank you so much, Dr. Leslie Soto. If everyone can come, Maria, if you can turn your camera on so we can start our Q&A section, that would be great. The first question that I have is for Maria. Are there any specific strategies that you have found most effective at ensuring some form of continuity of care for those that age out of the treatment centers for pediatrics while moving towards adult care?
You know, I don't know. I am so sorry. I'm having computer trouble. I'm trying to get my video camera to come on, but I can answer the question, and I'm so sorry. I'm still trying to get the camera on. Where I was the HTC nurse, our program, we had an adult pediatric hematologist. So those patients were from birth to 18. And then once they turned 18, we were fortunate to have an adult hematologist. So they just went from exam room 6 to exam room 7 because that's where the adults were seen. So it was the same staff. It was everything was the same. However, I do know that there are other patients. I know in our children's hospital, it's hard because our children's hospital here in Chicago, Lurie's Children's Hospital, has an HTC. But once the patients turn 18, then they are told they have to go to an adult hemophilia treatment center. And that's where it gets hard because they have to decide and if they're going to go to Rush, are they going to go to Northwestern? Are they going to go to Loyola? And some of those do not have HTCs. They just have adult hematologists. So it is a difficult task for those. Now that I am with the local chapter, I have more interactions with patients, not just those obviously from my HTC. So it is, I try to help as much as I can and get them involved with at least a physician so that they can go from that role of a pediatrician to adult. And I think for a lot of them, it's hard. I know that we once had someone that said, you all baby your patients too much. So then when they become adults, they don't know what to do. But that's not what we do. We just care for them and we want to make sure that they are, transitioning and that they can then take care of themselves as adults. So I hope that answers the question. But yes, it's hard to, in many places, it is hard if that transition is going to a different institution from pediatrics to adult.
Definitely. Thank you, Maria. Oh, your camera's back on.
All of a sudden, look at that. I'm here. I'm still here.
Thank you. I do want to be respectful of everyone's time, and I know we've hit the 3 p.m. mark here. Gabrielle, I'll pass it on to you to end the session. But thank you both, Dr. Leslie Soto and Maria Herrera, for a wonderful presentation today.
Welcome.
Thank you, Karina. And yes, thank you again to both of our speakers. These were amazing presentations, very, very informational. We appreciate you. We encourage everyone to complete the brief survey that you'll receive after this webinar. Completing that helps us to ensure that we continue to provide helpful information and content. If you are not already doing so, please follow us on social media at Accessia Health. To learn more about presentations and other webinars, upcoming webinars, including the final part of this 3-part series, Connecting the Dots, Coordinated Care and Community Resources for Bleeding Disorders, which will be held on December 4th at 2 p.m. Again, we thank all of you and look forward to your feedback. Have a good afternoon.
Bye now.
Thank you, everyone. Take care.
Bye-bye.